Okay, good evening. Welcome to the MyCP webinar. My name is Paul Gross. I am your host for this evening. Tonight's webinar is going to be about classifying pain in adults with cerebral palsy. Got a great group of people, leaders in our network that all are very passionate about this topic, most of whom see adults with CP, and I think you'll find the topic very interesting, and I think we'll have lots of good discussion too. So the agenda is going to be the sort of the usual agenda for how we do these. I'm going to give a quick intro to the CP Research Network for the two people that have not been to our webinars before. And then we'll go into the presentations on classifying pain in adults with CP. And then we'll have a good chunk of time for discussion. Okay, our mission is to optimize the lifelong health and wellness of people with CP and their families through high quality research, education, and community programs. To give you an idea of what we've accomplished since our founding in 2015, we've made a lot of progress on education with distributing of our toolkits and translating them. On research, we were really founded around creating a registry, and that registry now has more than 8,000 people in it. We also have a community registry that many of you participate in with nearly 2,300 people. We are patient-centered, so we have a patient-centered research agenda that numerous of you participated in creating, and we've gone on to get significant funding milestones from the National Institutes of Health, and more recently formed a partnership with the largest private funder of CP research, CPARF. We have 29 study concepts that are either under development, have been applied for, or are executing currently. It's a very full pipeline. And we have 4 quality improvement initiatives going across the network. And we're going to talk about one of those extensively tonight and how we're also hoping to extend that into research. We have had 10 publications, 39 academic presentations, and we're still writing a lot more manuscripts about our findings. So we're very active. And we have a great wellness program that if you haven't participated in, you should check out on our website called Mentor. So we are a 501c3 with a data coordinating center, or basically a place where our databases are stored for both our clinical and community registry. And then we have our education and well-being programs. If you haven't signed up for MyCP, I'd recommend it highly. It's how you can more deeply engage in all of our work, and you can make a difference by contributing your life experience to our studies. So registries capture data about people either in the community or when they come into the clinic, into the hospital. Gross motor function classification system is the way we classify how people move through the community with levels 1 through 4. You can see a sort of a U shape here in the community, in the clinical registry. And then from an age perspective, we have about 22% of our people in the registry are adults in the clinical registry. But in the community registry, we have a very different distribution of GMFCS and a very different distribution of age, which is represented by the number of people that are adults that are on this call. So those are our programs. There's a subset of our research and quality team having gathered in the University of Michigan in 2019, some of our health and wellness program, and then our community, they came together, 45 people split pretty evenly between community members and clinicians for setting our research agenda. We're spread all across North America. We have over 30 sites that are engaged in the work of the network, and then numerous of those are actually lifespan centers. So they're actually seeing people from kids all the way up into adults, and several of those sites will be represented here today. So with all that, I'm really excited to start to turn it over to our speakers. Tonight's speakers are investigators in a study of pain classification that we submitted to CPARF. We are waiting with bated breath to hear decisions on 5 applications that we put into CPARF. They're making decisions. They've made decisions, but we will hear whether or not we got a positive result this week. So hopefully we'll have some things to shout about. So these are our speakers tonight: Dr. Amy Bailes, Dr. Mary Gannotti, Dr. Ed Hurvitz, and Dr. Garey Noritz. And without further ado, I am going to turn it over to Dr. Noritz to share a little bit about the importance of this topic.
Hey, thanks, Paul. And everybody, if I haven't met you, I'm Garey Noritz. I'm a internist and pediatrician, which means I take care of both adults and kids with disabilities, in particular cerebral palsy. Um, I had just sort of a few comments about the pain that I see in my patients in clinic and some of how and why we're very interested in this topic. I don't think this is going to be news to any of you that pain is really common in adults with CP. Um, and occasionally patients will ask me, is that normal that I have so much pain as I'm getting older with CP? And I sort of hedge that a little bit because I'm not sure what normal means. And what I say is that it's really common, but that doesn't mean it's okay. I think if we say it's normal, then it's okay that you have pain, and we shouldn't think about it. And that's really just not the case. We need to think about it. We need to treat it as best we can and see what we can do about it. As clinicians, doctors, therapists, and everybody else, it can be pretty difficult to evaluate these kinds of pains. They're often pretty vague. Sometimes they're not. Sometimes it's very clear why somebody has a pain, like they have dislocated something or broken something or have a kidney stone and have symptoms that very much sound like that. Um, uh, but many of our patients have communication difficulties, and they can, I think almost anybody can express that they're having pain, but some of our patients really have trouble saying where the pain is or how bad the pain is or anything like that. As doctors and other clinicians, we need to remember that all the things that can cause pain in an adult can happen to an adult with CP. And so that's like, you know, anything that could happen to a person can happen to a person with CP. And so we can't focus just on the things that happen more with CP, but there are certain things that we know are more common in adults with CP, particularly musculoskeletal kinds of problems. And a lot of that has to do with abnormal mechanics over the lifespan. Kidney stones, like I mentioned, constipation. These are very common things we see in kids and adults with CP. And the last thing I wanted to say is that the history and the physical are really important for trying to figure out where the pain is coming from, what's causing it, and what we can do about it. And we tend to rely a lot on X-rays, CAT scans, MRIs, lab tests, these kinds of things, but you really need both a supportive history as well as maybe if you can find some abnormalities on a test, because just because there's abnormalities on a test doesn't mean that's where the pain is coming from. And I certainly have lots of patients where it looks like terrible arthritis in their hip, but we treat it in one way or another and it doesn't get better, or we find a kidney stone and we treat that and the pain doesn't get better. The presence of an abnormality doesn't mean that that's the thing that's causing the pain. And so, it's really a sort of a clinical a scenario, putting together the description of the pain as best the person's able to tell us, the exam that we see when we examine them, and then whatever testing we do after that. So I'm going to stop there, and I actually have to stop and return a page from a patient. I don't know if it's a pain related question or not, but I'm going to take off and I'll be back on.
Okay, I'm going to share my screen, I believe. Y'all see my slides? Is that a yes? Okay. Hello, everyone. I'm Amy Bailes, and a physical therapist and researcher at Cincinnati Children's Hospital with a faculty appointment at University of Cincinnati. And what I bring to this team is experience with quality improvement, and that's what I'm going to talk about with you today. I head up the quality improvement efforts of the network. And what that means is that we're doing things at the point of care to improve care and outcomes. So we'll talk a little bit about what that means in relation to this project, the adults with CP. At the beginning, well, in general in healthcare, there's a lot of variation in what we do. I'm sure that a lot of you have experienced that. And ideally, we'd like to decrease the variation so that we can improve care and outcomes. So we do that through quality improvement methods, and we learn from this to get better at what we're doing. So the Cerebral Palsy Research Network, when they formed, they decided that improving care for adults was one big area that they wanted to improve upon. And this is the people that you see on this slide that are part of this group. Lots of different centers, some people as consultants, 2 adults with CP, Duncan Wyeth and Jody Kretschmer, and providers at different institutions. So in trying to improve care for adults with CP, there's obviously lots of things one can do, but the group decided that taking care of adults with pain and assessing pain is really, really important, and we must start there. So on this slide at the top, you see, except I see this little, okay. You see these steps, this timeline across the top about quality improvement steps that you do as far as refining the scope and establishing a charter, what you want to do. You always document the current state before you do anything, so you can see if there's a problem with it. Then you define your aim and measure as far as what you want to improve upon and how you're going to measure it. You develop a theory or a key driver diagram that sort of outlines the things that you might try to do to see if you can affect change and actually improve upon what you're trying to improve. You test those things through many cycles. That's why there's those arrows circling back. And then once you achieve your goal, or if you hit your target of what you want to improve, you see if you can sustain it. So that's exactly what we set out to do. And what we started with was we needed to start with a chart review, looking back over the records to see how often the providers were documenting the pain and its effect on function, because they felt it's not good enough just to say somebody has pain. So a retrospective review of records across 3 institutions indicated that 29% of the time, the providers were assessing pain and its effect on function. So that's kind of our starting point, right? And there we go. With regard to defining the aim, we had many conversations. We reviewed the literature. We know there's some tools out there to evaluate pain, and some are quite lengthy. So we settled on these things here on this slide at every new or follow-up visit. So not including visits where you're just getting a Botox injection or maybe your pump refilled. We want the provider to ask if the individual has pain and answer it and select these answers. Do they have no pain? Do they have pain that does not affect activity, pain that prevents a few activities, some activities, or most activities? And we didn't make this up. This was taken out of a published paper where they used this scale called the Health Utility Indexed 3 Pain Subset. So this is what we were defining, that moving forward, we were going to measure how often in a visit the provider assessed or asked the client if they had pain and how they answered in these ways. So this is what I was talking about, sort of an outline of what you think will make the changes. This is called a key driver diagram, or the theory of improvement. On the left side in the middle, you see our SMART aim. SMART stands for specific, measurable, something, something, and time bound. So we wanted to increase the percentage of adults that were with CP that were 18 or older when they come to their visit, that they're screened for pain that limits activity, from that 29%, which was our baseline, to 80% by December 2022. The top of this left column is the global aim, which overall we want to improve quality of life for adults with CP. So we could have many SMART aims over time, but for right now, we were addressing being screened for pain that limits activity. In the bottom left, you see this is how we defined screened. Like I said, the provider would ask the client if they had pain, and how they answered the question would be documented like so. In the middle are key drivers. These are things that we think need to be present in order for us to be successful with achieving our aim. And on the far right is what they call the interventions. And this is the things we did as a team to change the environment and the processes to get this to happen. So we trained everybody on the team. We reviewed the literature to come up with what we wanted to do. We developed cooperative relationships with other people on the team, other people that might be seeing the clients. And then we created some definitions. We standardized the process. We created a SMART phrase, which is a word to explain a certain type of, let's see, documentation thing in the record, in the medical record. For those of you that don't go into Epic regularly, which I'm to write a note, which I don't think people do. And then the last intervention block you see there is changing the work environment. So a big part of quality improvement is giving people access to the information. And we did this by way of having phone calls every 2 weeks where people would enter and document how many patients they saw and if they assessed for pain and answered these questions. And we give feedback to people so that we could get feedback in as close to real time as possible, which has been shown to affect change of behavior. So here on the left is the SMART phrase that is in the notes that the providers are writing. And if you click on that SMART phrase, then these things pop up, and it's sort of a way to do it faster. And then access to information, we met every 2 weeks. We have special kinds of charts and feedback that are quality improvement methods. And all this information was on our Teams channel where the quality improvement group works from, so you can see it. And it's very transparent, I guess, is what I'm trying to say. So this was where we were testing these different things, and that's where we settled on. So this is one of these fancy charts that kind of shows where we started. Baseline is down here. This is actually over 40% because eventually we removed one of the sites for the baseline phase. And then, but we did, as you can see, different centers nationwide in Columbia. So we started out low, and then these blue dots are every 2 weeks that we collected data. And as you can see, the blue dots start to go up, then they start to really go up here, and we're way almost at 100% being screened. Then Columbia started to use it. Then we started to record how they answered it, because at first we just wanted to know if they screened for pain. But then we were like, we need to know how they answered the question, right? According to those 5, the pain that doesn't affect function, etc. So as you can see, we've been pretty stable. We've been over 90%. All these little blue dots are kind of close to the red line. So that's a good sign. So we've currently exceeded our goal of 80%, and we're over 90%. And that is in the process of being written up and submitted to a journal. Mary, I wasn't sure if you were going to present this or I was supposed to present this, the participants in this.
Go right ahead.
Okay. So if you look at the bottom of this chart, the data collection started in 2021. And then on the far right, it goes through June 2023. So for the first while, we didn't have all the characteristics of the individuals. We were just screening for pain. We didn't have how they recorded the answer. But since they were recording the answer, that started in October of 2022 and went through June of 2023. So during that time, we then looked at the number of adults the number of visits that adults had, and there were 454 across the centers. And as you can see, the age in years was 31 and a half. 225 for female. GMFCS levels you see here from 1 to 5. More were levels 4 and 5, and some were missing in these 454 visits. This is how they answered that question. Of the 454, 413 were screened. And again, this is how they answered. 238 had no pain. 82 had pain that did not prevent activity. 47 had pain that prevents a few activities. 36 some activities, and 17 most. So we're starting to learn about the population of adults that are coming to these centers. And then Mary did some statistical analysis to look at the differences in how they're reporting pain based on these 454. Mary, do you want to say something about this slide?
So in the sample, just looking at the people that reported pain, the older that you were, the people that reported pain were older than those that didn't. And they were more likely to be female than male. And we did not really see any difference across the functional levels, whether you walked, just with a little bit of some sort of noticeable difference, or if you didn't walk at all and used a wheelchair and, even had difficulty holding your head up. So we didn't quite see in this sample a difference among physical levels either.
So that describes the quality improvement work across the centers. And the next thing that we're going to do, like the title of this is classifying pain. So far, we haven't done any of that. We've just been screening for pain and then documenting if pain limits function or not. So this next phase on the bottom of this slide, it consists of 3 steps. And I think Mary would be the best person to describe this. Do you want to go from here, Mary? You want me to close out and you'll bring up your slides?
Sure. Well, I mean, we're looking at how to classify pain. And so I think what we're going to talk about next is see about the different pain types and how we might do that.
Yeah. And the reason we think that's important is because treatment will vary depending on what type of pain and how it's classified. So that's a very important step to getting the right treatments. Okay. Thank you. Any questions on that before we hop over to Mary's slides?
I think that could be a slippery slope, Amy,
Okay.
to jump to questions. Because we don't have that long of a presentation. Let's save the questions for the end.
Sure. Okay. Next.
Okay. Can you see my, okay, perfect. Everything's good here? And you can hear me. And my dogs are just decided to howl. Hello.
We can't even hear them.
Perfect. Thank you for coming tonight. And you might have heard some of this information before, but we kind of want to bring all of it together. I'm Mary Gannotti. I'm a physical therapy professor, and my clinical practice and my research is focused on adults with CP. So I'm just going to talk a little bit about what the community registry has and other tools to consider in terms of looking at pain types. And we'll just talk a little bit about what we found in the registry and how that might inform what we're doing in the quality improvement study. So in terms of our community registry, which you access through MyCP, and is not a sample of folks who come from these tertiary centers, but could be a mix of living in the community and receive care at these centers. We had 78% who reported chronic pain, and 73% of those, which is a very high percentage for a voluntary survey, completed the chronic survey bundle. Just to give you an idea of, chronic pain is very widespread in this population. The average age of onset was 28 years. And when we looked at pain intensity and its variability by people's ability to ambulate with or without assistive devices or use a wheelchair, there was no differences. And there was also no differences by age group. So I think that's sort of is interesting to think that the folks who were filling this out, the sample, they were very much in pain across all levels. What do we have in the community registry for evaluating pain? We have something called the brief pain inventory. And this will give you an idea of pain intensity, pain location, pain interference in many different activities, and your response to treatment. And this measure, in conjunction with other measures of depression and anxiety, are what are recommended by the International Association for the Study of Pain. And this measure is used in chronic pain registries in the United States and internationally. So we're excited that we have that in our registry. We also have these measures called PROMIS, and they're created by the National Institutes of Health. And what is nice is that they provide a score that tells you where your participant falls in relation to a really large sample of people in the United States. And it's called a T-score. And the nice thing about these measures is that they're embedded in the electronic medical records. Some of them are called EPIC, and there's also another computer program that's widely used in hospital called REDCap. And it allows for providing the questions in the most efficient way as possible, meaning computer adaptive testing. They ask some of the same things that the brief pain inventory does, but remember, it gives you normative scores and it doesn't give you that picture of the whole body. And then we also have those same types of measures that are normed to the US population for depression, anxiety, and satisfaction with social roles. Because your emotional life really impacts how you perceive and respond to everything. And it's really important for pain, which can be a combination of experiences. So when you look at what the brief pain inventory gave us from the community registry, trying to see if this would be useful to use in the clinic, you can see that we have an indication of that pain intensity from moderate to severe pain. And these little boxes here, this is the median, and this is the lower quartile, and this would be the upper quartile. So you can see that it's useful in that you can gauge where somebody's pain in for the range of mild, which is 1 to 4, and then more moderate to severe, which is 5 to 10. So that's helpful. And similarly, we get the same type of information when we're looking at the median and the quartiles, or just where someone rates their pain interference. And just to remind you, or to show you if you haven't seen it before, we can see the greatest interference in work, in ambulation, and sleeping, which is not anything new. It's things that we've heard in the clinic and that our participants and athletes or patients have told us before. And the nice thing that I like about the BPI is the body, where you can show where your pain is. And you can see it's indicated on here. The folks in our registry had an average number of 8 locations with a standard deviation of 5, and some people ranged all the way to 23. But when we look at these areas, the low back, knee, hip, and leg, these are the most prevalent areas. But interestingly enough, when we think about where we might see in the typical population, just like Dr. Noritz said, whatever can happen to an adult can happen to an adult with CP. We see this thing called pain centralization or nocioplastic pain in the people, the non-CP population, or people without CP, in folks that have lateral epicondylitis. And that would be, that's like elbow pain, which you could think would be really prevalent in people that are using assisted devices for locomotion, chronic low back pain, whiplash, neck pain, low back pain, knee osteoarthritis, and impingement syndrome, which is often at the shoulder. So these areas that show nocioplastic pain, which we'll talk about, are prevalent the same areas that we see in folks with CP. And again, when the BPI asks our folks about pain treatment, and their pain, if it was better or worse, and we can see people tend to be getting worse, and their pain is not well treated. So the BPI is helpful, and then it gives us information about responsivity to treatment and pain progression. So this chart here is from the International Association for the Study of Pain. And it's a paper that was published a couple of years ago in 2019. And it's telling us that chronic pain is really a disease. And what we should do is think about chronic pain as either chronic primary pain or some chronic secondary pain syndromes. And asking us that when we identify if we have a primary source of pain, whether it's widespread pain, one of these things, or if our chronic pain is secondary from one of these other types of conditions, like cancer, post-surgical, neuropathic, visceral pain, which would be just like stomach pain, gut pain, musculoskeletal pain, then after we've identified if it's primary or secondary, then to try and differentiate what is nociceptive. All right. And nociceptive is something that's mechanically deranged, so that if we can alleviate that. Neuropathic, which is nerve damage, or nocioplastic, because there's different treatment pathways. Okay. Now, as a clinician, when I am trying to decide if your pain is because you have a splinter in your finger, I'm going to do a clinical examination or the patient response to treatment. Is there some sort of mechanical alignment problem or something that is really triggering the nervous system that I can alleviate by removing the mechanical derangement or the mechanical thing, or giving some anti-inflammatories? So I'm going to give you a clinical exam, take some history, and see how you respond to treatment. When someone has neuropathic pain, which is pain from some sort of nerve damage, I have to do a little bit more in-depth testing. I might do some patient questionnaires, and I might do like nerve conduction velocity testing, or some sort of testing where I'm putting monofilaments, little filaments on you, specialized testing. Nocioplastic pain is similar to the one above, where I'm going to have to look at your history, your clinical examination, how you respond to treatment, and perhaps give you some questionnaires and do some specialized testing. Here's a clinical decision tree that was published by the International Association for the Study of Pain. And if you have pain that is not more than 3 months, they'll say this is not chronic nocioplastic pain. And the problem with nocioplastic pain is that you have an over response when you have your pain signal. All right. So this clinical decision tree will help us as clinicians to differentiate the type of pain that our consumer may be experiencing, and that will help us decide whether or not we are going to do certain treatment activities. So the neuropathic pain questionnaire, here's one. It's called the Pain Detect. And again, we have a nice image of your body where you can write what hurts. and you will be asked questions like, do you suffer from a burning sensation? Do you have a tingling or a prickly sensation? Is light touch, like clothing or a blanket, painful? Do you have sudden pain attacks? Is heat or cold very painful? Do you have numbness? Does slight pressure trigger pain? So this has been used with adults with cerebral palsy, and this gives us an indication the degree that a person may be experiencing neuropathic pain. Nociplastic pain questionnaires include the central sensitization inventory, and you would be asked questions like, my muscles are stiff and achy. I have anxiety attacks. I clench my teeth. I have problems with bright lights. I get tired very easily. I don't sleep well. Smells and perfumes make me dizzy. I have low energy. I'm depressed. I suffered trauma as a child. I have pain in my pelvic area. Another way that and now let's see, we had another study by clinicians, and they said you need to do all of these certain clinical tests, but they all preferred the central sensitization inventory for folks to provide self-report for pain that had centralization. There is another self-report measure for nociplastic pain. And remember, nociplastic pain is when you have an overreaction to a sensory stimuli. And this has been used with adults with cerebral palsy also. And it's a measure for fibromyalgia. And here you would indicate the areas of your back or your body where you have your pain. And then you have list your symptom severity around fatigue, waking unrefreshed, and having cognitive symptoms. And then you also have other symptoms that you would mark. And you derive a score from this, and this will help diagnose whether you have fibromyalgia, which is a form of pain centralization where you experience your pain, not in response to the stimuli, but an over response because there has been some sort of central change in your central nervous system. So those are the measures that we have. These are measures that we're considering for clinical use. And now I'm going to turn it over to Dr. Hurvitz.
Mary, go back to your slides. Do you have my slides on your slides?
Yeah, they're right here.
That's not it. Oh, you give me a title slide. Okay, great. Hi, everybody. I'm Ed Hurvitz. I am at the University of Michigan. Go next slide, Mary. So the thing that we've been talking about, and we've been talking about this all through, is it's very important to get it right. People with cerebral palsy have all three kinds of pain. The nociceptive pain, because people with cerebral palsy often have arthritic joints, or they have tendinopathies because their movement patterns are different. They have the neuropathic pain, for example, they might get carpal tunnel from walker use, from pressing down with their hands and their wrists, or radiculopathy, which means like a sciatica from spinal stenosis. Or they might have the nociceptive pain, nociplastic pain Mary's been talking about, but we're not sure what causes that, but certainly having chronic pain contributes. And there's some talk about the kids in the NICU who get a lot of the neonatal intensive care unit, who get a lot of procedures done with that, might be set up for their whole life for having a chronic pain and might be more susceptible to nociplastic pain. So proper diagnosis leads to proper treatment. The circle graph, the pie graph over here shows in the blue, this is a group of people with cerebral palsy. The blue was nociceptive, about 39%. Nociplastic was about 24%. 11% was neuropathic, and a mixture was 16%. So you see, people with cerebral palsy have all kinds of pain. Mary, next slide, please. So I just want to talk about a couple of cases to illustrate the point. So you had a 48-year-old man in your clinic, and he's got an arthritic hip. He's he's had that for many, many years. This is related to his hip being subluxed because of cerebral palsy. And he comes in with chronic pain in his hip, his back, and both arms, which has nothing to do with his hip. But the clinician is really focused on the hip because they know that people with cerebral palsy have hip arthritis. So they get extensive treatment. They get medications. They get injections into the hip. They get opioids. And the graph on the other side of the slide is from a study that was done again by Dr. Peterson that shows opioids given to people with cerebral palsy and people without cerebral palsy. People with cerebral palsy, their amount of opioids was up here compared to people without cerebral palsy, and the same comparison between here and here for a different situation. In every case, people with cerebral palsy tend to get more opioids, and it has a lot to do with the fact that we don't identify the pain well, and we just give people opioids because we think that here's someone who will really benefit from the opioids because they have really bad arthritis. But it's a real problem for everybody, and certainly cerebral palsy. The individual will finally have surgery, and after all that treatment, they're still having pain, and the reason they're having pain is because the clinician missed that they really have nociplastic signs and symptoms. So all these treatments are not effective for nociplastic signs and symptoms. You need a completely different treatment. Next slide, Mary. So here's a case of a 32-year-old woman with back and leg pain. And she was having this pain and she was having some trouble walking. And she was just told, you have cerebral palsy. It's getting worse. Cerebral palsy is getting worse. So we sent to the pain clinic. And since she had all this pain, they told her she had nociplastic pain. And they gave her some antidepressants, and they gave her some Neurontin, and they gave her these medications, and continued to get worse. And then finally, they did the MRI scan, and they found out that she had spinal stenosis, which means that the discs are pressing on the nerve, and there's arthritis at the joints, which are pressing on the nerve. And then she had surgery, and you know what happened after her surgery? Her cerebral palsy got better because she stopped having so much pressure on the nerves. So again, a misdiagnosis leads to a mistreatment. Next slide, please, Mary. So in summary, for all the talks you've been hearing today, pain is very common. It's a major problem in people with cerebral palsy, interfering with quality of life. We need to get better working with pain. Quality improvement efforts like the one that Dr. Bailes presented across a network like the CPRN can help. Pain comes in different forms like Dr. Gannotti presented, and there are tools to help us determine the type of pain. And I just told you the proper and timely diagnosis of pain leads to proper treatment. So next slide, we'd like to hear your questions and your thoughts, and we can stop the share.
Great. Let me say thanks to all of you for the presentation, and we'll just, people can either ask their question, or they can raise their hand, or they can type it into the chat, and any of those will work, and I'll just try to moderate all of those. This is not a quiet group, so I'm really expecting that there will be questions. That said, I'm not looking at the view where I'd see a hand, although I think it comes up to. I find it hard to believe. Okay, Chris Geddes, you get to ask the first question. You're muted, Chris, just so you know.
Sorry, can you hear me now?
Yes,
Yeah.
we can hear you now. Fire away.
Okay, great. First of all, I really applaud everybody for this study and what you're doing. I made some notes for everyone, but I'm going to address with a couple comments first and then a couple questions. If it's okay, I'll keep it to 2 minutes, Paul.
Okay.
So when I'm looking at the fact that you are evaluating nociceptic and nocioplastic pain, my first thought here is, people with cerebral palsy, I didn't hear those words until I was in my 30s. And I'm sitting there telling a therapist, what does this mean? So the reality is, I think we need to develop a language where individuals know how to communicate their pain, because I don't know how your studies would combine this, but it would appear to me that, at any given moment in time, the likelihood that the individual with cerebral palsy only has nociceptic pain and doesn't have nocioplastic pain may be pretty low, or in fact, it may be just situational, because post-surgery, you're going to have that type of pain. And all along, I would say to you that the ability, pain may not change as much as the ability to endure the pain. So in other words, you know, if somebody can't handle temperature change, that's nocioceptic. But that might go on all along. Well, if that pain goes away when the weather is different and somebody only has a certain amount of time to talk to a physician, how are we going to help the dialogue? You can do all of these studies, but the reality is a nurse will say, fill this out, and then they call your name before you filled it out. And so then it's not even completely filled out. So, you know, and some people can't fill it out. So what type of education would you suggest to give at different periods in the lifespan? But since we got so many adults, that allow patients to better identify their own pain and are able to call it acute or chronic or the different types of pain. Because I think that your ability to get correct answers sits at the base of some of that.
Great point.
Ed or Mary, or, oh, Gary, you're back. Who wants to take that one?
I mean, I think it's great to hear this information, because that's what we want. We want to know what you think would work. And what I think I hear you're saying is that we need to share teach people about pain and the different types of pain, so that you can talk about your own pain, right? And not wait for someone to give you a survey that you can't complete because you don't have, nowadays, we don't keep you waiting in the waiting rooms, right? Because, yeah, I mean, that's a real thing that speaks to me. Like, we have tablets in our clinic, but
well, you indicate, Amy, you said pain that affects all activities, few activities, some activities.
right.
Well, you know, I would say to you, when I work with students and they go around the college and they're carrying books and then they're exhausted, the susceptibility to pain is different when their energy burden changes. So that's where the snapshot that you get in a moment of time, it would be really great if we had something like where they have blood pressure monitors, heart monitors, where somebody has to have a little monitor and they can, you know, monitor throughout the day with their logs of what goes on. And if we could give somebody a tracker and say, take this home with you for 30 days, and I want you to push the green button if it's this kind of pain and the blue button if it's that kind of pain. Like, that's a device we could create.
That is, I don't even think you need to create a device. I think you could do that on the phone. That's a study design that somebody could, you know, if we can see if someone's passionate about it, I'm sure we could do.
I'll do it.
Let me see if there's anything else to answer about Chris's question from our speakers. I'll take that. Otherwise, I want to take the next question in the chat. Okay. Next question, Kara asked, where do I take my daughter? I'm in Nashville, Tennessee, to determine which type of pain she deals with most. Pain clinic, psychologist, orthopedist, PT. This is a great question. We've been talking about that. Somebody from the crew want to take that?
Well, a pain clinic is a good option, but the thing is that pain clinics are not they have the same problem as many other clinics in terms of not understanding people with cerebral palsy. So, you know, I'm prejudiced, but I would say that taking the person to a physiatrist or a physiatrist, physical medicine rehabilitation doctor who sees adults, they will have experience with pain in people with disabilities and perhaps some with cerebral palsy. So I think that's a good place to start. And I don't know people in Nashville, Tennessee, but I think that's that may be a good place to start.
I actually know people in Nashville and could probably get a reference. If you send me mail, Kara, as to the age of your daughter, that'll help me with my contacts there, and we can see if we can get you someone to refer to.
Wonderful. What kind of doctor are you saying? A physiatrist?
Physiatrist, physical medicine and rehabilitation.
Okay, thank you.
And you can send me mail at paul@cprn.org with more details, and I'm glad to help. It's one of the sort of freebies that we do is try to help people find referrals through our network. June Kales, you're up next, and then to Chris Myers from the chat.
Yes, yeah, I really like this. But it is multiple exposure content for those of us for who these terms do not roll off our tongues. But the language of how we describe pain is really something that I think a lot of us that I know I struggle with in terms of being, you know, helpful descriptions, robust descriptions. So my question is, are there tools that you could provide to the network, you know, kind of self-descriptive tools that we could use to help us be better at describing our pain and then presenting it to, you know, many of us don't relate to these clinics or don't have these few clinics to go to, but have to start with the kind of the vanilla place that doesn't know CP that well. So I think any tools you could provide that are kind of for self-use and would help us be more descriptive of our pains. I know you've got a number of surveys we've taken for you, but it would be good if you kind of reversed it and gave us some tools.
We are just at, I will say, and Mary probably can comment on this more, but we are just at the point where we're starting to take some of these patient-reported measures and try to create them as tools for you to be able to bring into the clinic or to, you know, mail to your clinician. So, but it's a very a good point. Mary, did you want to add to that?
So, I mean, all of the questionnaires that I talked about are freely available PDFs on the web, and I uploaded them on Teams under a certain folder that if, you know, Paul wants to make them available some way, we could.
Actually, just to be clear, Mary, when they take the adult study, they get those PDFs and they can bring those, they could,
Okay,
for
so
those
what Paul
tools,
is
they
trying
have
to tell,
access to them.
so you have the BPI in the MyCP, you have the promised pain interference. So you can bring those to your provider and that will give them rich information. The brief pain inventory and the promised pain interference will give them, like I said, T-scores and all of that descriptive information. So those are there for you to use.
Okay, so you actually.
And then in terms of the ones that we're looking to use to differentiate between neuropathic and nocioplastic are certainly easily available, that we could figure out how to make those available, and the pain detect and the central sensitization index.
That is a very likely outcome of this work that we'll do, is we will not only develop tools for the clinicians, but tools for you.
Yeah. I almost wonder if those assessments and the BPI and stuff we need to explain them a little bit more in easier terms and to make it easier to use for folks. So that would be something
like
we'd love your input. Mm-hmm.
I think it's important to the way that you put it, June, was just right. You need some tools to tell how you describe your pain. I would caution against these kind of tools to self-diagnose. Self-diagnose is usually not a good idea. It's good to try and understand how you describe the pain and bring that to a physician, a clinician who can help you work through it.
So I'm going to pause for a second. We went longer than we anticipated, and I know there's a lot of questions queued up. I know it's late on the East Coast, so I won't feel bad if anyone needs to check out, but I would love it if I could get some of our speakers to stay a little longer to answer a few more questions. So I apologize, but if you would do that, that would be great. If you need to go, just wave goodbye. There's a question from Chris Myers that's sometimes I have pain in my back. Now I may be overweight, but I think there's another issue. How do I ask to see if there's something going on?
I would think that you just describe the pain as well as you can, describe some of the treatments that you've had. Generally speaking, when I have someone who comes in and they've had, you know, if I think it's just because they're overweight and they're having problems with muscles in their core, but they've had physical therapy, then I say, well, then it's time to look for something else. So giving your doctor a good understanding of where the pain is, where it's spreading to, and what treatments you've had can be very helpful in terms of getting the right diagnostic tests.
I also know that pain that fluctuates in your back, you know, you need to really describe that. Like, so like June was saying, when does it hurt the most? In the morning when you wake up, at night when you're sleeping, after a long day at work. Those kinds of things are really important. And it is, although physical therapists are very helpful, it's really important to see a doctor who can decide whether or not you need more differential diagnostics like imaging.
Great, thanks. Paul Staunches says it's important to measure, is it important to measure pain that affects preventing participation in activities or pain that affects their participation in the activity?
I'm not sure I understand that.
Paul, do you want to specify like a little, give an example maybe?
Yeah, so maybe I'll have second thoughts about doing something because I know it's gonna be relatively painful, but it's still something I want to do, so I'll go and do it. So, is it worthwhile measuring pain that not necessarily prevents me from doing something, but it definitely affects my me deciding to participate in that?
So you don't have pain yet, but you know, if you participate in it, you will have pain. Is that what you're saying?
Exactly.
Yes.
Oh, I see.
That's pain. Yeah.
I would sort of say that it's preventing you from doing that activity. Is it because you have pain now, or you're gonna have pain if you do the activity?
Yeah.
And it's important to note that the HUE, which is the measure that we used, is not perfect. It's not really intended to measure. It's really, we were trying to make sure that a consistent dialogue happened across all of our centers. And it was very effective from that perspective. But there's a lot more that we need to do.
It's also important to note that that understanding when the pain occurs with what kinds of activities, there's a difference in diagnosis if pain occurs when you're going up the stairs or going down the stairs. So it's good to talk to the doctor about, you know, I don't like to do this because it causes pain, and where it causes pain based on certain activities.
Okay, I'm gonna, there's some comments that our speakers would value in the, just about sort of frustrations and whatnot. 2 time slots for appointments. So Chris Geddes mentioned the issue that we discussed on a call recently about 2 time slots for appointments would be helpful. Does anybody want to comment about the challenge we're facing with trying to do these assessments and make sure that the appointment has sufficient time, other than the fact that it's something we're looking at?
Yeah, it's a challenge.
It's a challenge. Okay, Morgan, go ahead with your question.
Hi, I just thought about this while you guys were presenting. I know personally for myself, I tend to, even though it's bad, I tend to suppress my pain because I feel like my tolerance is different than a lot of, individuals. CP or not, I feel like I have a pretty high pain tolerance. So I think in talking about these things as well for everyone that it does affect, when they're looking at a model or a graph or how you're going to report that or work with it, I think it's important too that at least for me, I know my tolerance is probably a lot more intense and more invasive, that I'm willing to admit when someone asks me like, where do you hurt? Are you in pain? Like, chances are it's not that I'm not going to tell you, but I can take so much that I feel as though other people I don't think necessarily would. So I don't know how that applies to the research. If you're a lot of the whole like non-CP people versus CP people versus are we being honest when we're giving you this information too? Because I feel like part of me would not be completely honest because I'm like, whatever. I deal with it. It's an everyday thing. Who cares?
Yeah, Morgan, that's a major problem when we see adults with cerebral palsy. I always like to tell the story of my patient that I asked her if she's having any problems with the falls, and she said no. And I said, "Oh, you haven't fallen?" She said, "Oh, I fell 3 times today, but I don't have any problem with it."
Yeah.
You know, it's same with the same with pain. You know, people tell me they only talk about pain when it goes up. They only tell me about the pains that's going up. You know, they don't tell me about all their pains because that would be too long a story. So you're right. People that don't have cerebral palsy would say I have a pain in my shoulder. Someone with cerebral palsy would just live with that, and that interferes with our ability to really understand things.
I will also emphasize, so this is a really great point, and thank you for bringing it up. It is something that Duncan Wyeth, who's he participates in this group where we do these meetings. We have 2 members of the community, and this is an issue that he raised about this. So it is, these are things that it's marvelous to have this kind of interaction and this kind of regular feedback on. I'm going to move to a question from Gail. Do you think that the increase in spasticity causes pain or pain increases spasticity? Would a goal be to control spasticity to decrease pain?
I think it's a cycle that we don't know exactly which comes first sometimes, but I think a goal would be to interrupt that cycle. And if that would mean controlling the spasticity, then yes. Anybody? I mean, Gary and Ed both dropped off the call, so you're left with PTs that can't prescribe medication, but yes.
Well, and one of the theories that we have is that, that's why it's so important to keep your muscles strong and build your muscles, because the spasticity might be, this early onset degeneration, combination sarcopenia, nerve degeneration, who knows what's going on. So, why it's so important to be active. But certainly it is a cycle, and it's really a difficult cycle to break if, you're sitting and it's really twisting your pelvis and putting your hip out and it's bone on bone. So.
If I can make just a quick comment on that one, I think maybe as leaders in the field, as an organization, we need to begin to advocate very strongly for the approval of Medicare and other insurances to pay for standards, because, we know that bone loss occurs in everyone age 30 and above. And so with CP, if you're not doing DEXA scans, you don't know how much somebody is beginning to experience demineralization, though you may know that they have vitamin D deficiencies or calcium deficiencies. So by simply looking at those 2 things, they may be predictive of the likelihood of osteopenia. And if you're not standing and you're not walking, then you have blood pressure issues. And those are both the reasons that standards should be approved in our population. But I know for a fact, having pooled a few people recently, I didn't have Botox for 57 years. I had it a month ago. And for the first time, we pulled my pain down by probably 20%. And it's just something that I never had. And so sometimes we may have an adult population that doesn't even know what to ask for, or we're afraid to use the modalities we have because we think we're going to maybe overcorrect for spasticity or something. But I thank you for letting me speak.
Yeah. And Duncan, I see your hand up, and I am going to give you the last word. I'm going to say about a lot of the comments in the chat. So part of what this group of physicians and therapists do is they're working on both standardizing the care that we can then spread, thinking about what kind of educational materials need to be available. So we're just getting there, and we appreciate your input on these types of things. And for your questions that aren't answered, you can post them in MyCP, and I can get the the physicians that had to leave answer those if Mary and Amy can't. But I want to just close with Duncan. You get the last word, and then we're going to wrap up because it is 10 after 9.
Well, I'm speaking to you all as kind of the elder of the clan here. I was 3 weeks ago down at the University of Michigan, and I'm looking at some possible spinal surgery infusion. But what has really come out of this is my regret. And I understand that diagnostics are expensive, MRIs are expensive, but I do wish that maybe 10 years ago, 15 years ago, we had established some baseline findings in terms of diagnostics, because now it's hard to determine whether this cervical stenosis and bulging of the discs and all that appear to be affecting my motor control, is this a relatively new development, or has this been developing for years? And so I know diagnostics are expensive, but I think all of us, consumers and providers, need to do a better job establishing different baseline sets of data through the aging process, so that we have something to work from.
All right. Is there anybody have a comment on that, Amy, Mary?
I absolutely think I agree with you, Duncan. That should be part of the clinical practice guidelines for adults with CP, bone mineral density and MRIs upon 21, so that you can track the changes over the lifespan. And I also agree with June Kales Isaacson that I think that, in fact, one of the reasons why we asked about pain that affected function is because we do know that people with CP live with pain. What we've heard is that they live with pain all their life, and they don't complain about it till all of a sudden they can't do what they couldn't do before. Whether or not it's a higher tolerance, like people with autism, that's a difference, because that's a sensory processing disorder. Some people with CP have different sensations, but it might be just the way that you cognitively perceive it, because your motivation is to succeed more than it is to feel your pain. And that might contribute to your cognitive overload with aging, because you have to work so hard to move and fight through the pain. So I don't think it's logical at all.
Let me just say thank you first to all of you that participate in our surveys, because getting, like Dr. Gannotti was quoting some longitudinal data we have about pain, which starts to give us a sense as to whether or not it increases or decreases. That's super valuable. I know that, these surveys take time, but we really appreciate it. And we're really starting to do a lot of publication off of them. We're using them to sort of drive future studies. So it's really an important way in which you contribute to the body of knowledge that we can use to improve outcomes, improve your lives. So thank you for taking the time. Drs. Gannotti and Bailes, thank you so much for your all that you contribute to this. Fingers crossed on our grant, so we can accelerate this work. That would be great. And thank you in absentia to Dr. Ed Hurvitz and Dr. Garey Noritz for their contributions to this work and speaking tonight as well. Thank you all. Good evening.